Welcome to Embedded Conversations, the podcast that explores what it takes to embed ideas, innovations, and partnerships inside the NHS. I'm Scott McKenzie, and I work with NHS leaders, commissioners, and life science companies to change patient pathways for the better. This podcast brings those ideas to life through shared stories from people inside the system who talk honestly about what works, what doesn't, and what it takes to embed change in the real world. If you're working in, around, or with the NHS and you want to understand how change really happens, you're in the right place. Hi everyone, welcome to the latest edition of Embedded Conversations, where I am genuinely delighted to welcome today's guest, David Thorne. David is one of those really rare NHS leaders who manages to be quietly influential, would be my observation. He's very consistent in his thoughtfulness and refreshingly honest about the realities going on inside the system, particularly when it comes to system change. In fact, I often get people joke with me, they never see David and Scott in the same room. And yet here we are today, and finally we're going to do a podcast together. Now, what makes this even more interesting is, for those of you that follow David on LinkedIn, you'd have picked up what I picked up a couple of weeks ago. He's just entered his 46th year working in the NHS, which in itself is remarkable. Even more remarkable is that despite everything the service has faced, David remains deeply engaged, optimistic where it matters, and unafraid to call out the things that really determine whether systems succeed or stall. In that post, David really reflected on how polarised the NHS feels right now, with some places racing ahead, embracing opportunity and collaboration, while others are really stuck and remain stuck. I think his conclusion was really characteristically simple but really powerful. Progress ultimately comes down to trust, to be the ability to compromise and teamwork across the NHS, and many tribes and organisations that have to come together to do that. Now today, I'm going to be talking to David about one of the things that he's been a real long-standing advocate for, which is value-based healthcare and outcome-focused commissioning using real data, including tools like Plix. So we're going to move into conversations way beyond the rhetoric and actually into practical deliverable outcomes. So let's see where we go. Risk sharing, value-based partnerships, and what good really looks like. David, it is an absolute pleasure to get you on today, and I'm really delighted that you've come to talk to us.
Thank you very much. It's very kind of you.
No, it's just a realistic reflection of the David that I know and respect completely. I've known you for a very long time, always had complete respect for you, and I've just tried to reflect that. But that LinkedIn post really did catch my eye because it was absolutely honest. In fact, I was talking about this to Alison Oliver, who I think you might know as well. Yeah, Alison's at Sentence. So Alison was one of the podcast guests, and we were talking about that to do the collaboration, you have to be prepared to forgo a little bit of your independence. You've got to let that go and trust that the neighbourhood or the network or the federation is going to act in your best interest. So it was just a really good reflection of what you'd said.
Yep. And what else I just wanted to add, Scott, for our friends out there, is I'll be very practical today. Okay?
Yes.
I know the questions, or I can guess the questions that you're going to ask me.
Yeah.
Well, I think it's very difficult at the moment for people out there, given all the chaos that's going on, to separate the rhetoric from the reality.
Oh,
and
totally.
if you're a key account manager for a company, what do you actually do?
Yes.
So it's a great opportunity for me to listen to you as well, Scott. Both of us are practical people.
Yes.
What practical advice can we give to people? Okay.
That's what we try and do. We try and keep it really grounded and practical. So, let's start then. Let's dive in. So you have been, and it's one of the things I picked up from you really early when I got to know you, you've been a real advocate for value-based healthcare. So from your perspective, what needs to happen for outcome-based contracts to move from that kind of pilot phase to be business as usual in the NHS? And is there a role for industry to really get involved and engaged in accelerating that transition?
Yeah, I agree. And I think it'd be really easy for someone out there or someone in marketing or in a head office function to think, well, I've heard it all before.
Yeah.
And where's the evidence of it? But firstly, I used to work in industry, carried the bag. I can remember selling in an outcome-based contract, wait for it, in 1997. Okay, these things can happen.
Happen.
They
They
can
can.
happen if the right
Yep.
ingredients are there.
Yeah.
So I think what's going to run through a lot of my responses today is segmentation, is finding the right partners.
Yes.
So you need to find people who've got that strategic breadth. So which accounts are moving further on integration?
Yep.
Just to pick up what Scott was saying at the start, don't think that was just his nice introduction. There's some really salient points in there around which areas on your accounts or nationally is where is that trust exist?
Yeah.
Where's some examples already that people work across primary, secondary,
Yeah.
tertiary care, GP practices can compromise, people can let you use premises. Where you've got that kind of flexibility, you might even start soon to see posts. I was at a meeting locally in my role
Hmm.
and met two young women, both consultants, and what do they expect to be? Clinical directors of integrated services, one
There
for
you go.
diabetes, one for
There
respiratory.
you go.
Yeah. So where are the areas moving in
Yeah.
that kind of direction? So there's some heavy segmentation, keep the faith. Other stuff that I'm sure we're going to get into, Scott.
Yeah.
Where does informatics exist that allow this to happen?
Yeah.
But I would immediately look for areas where there's local variations to traditional contracts, and there's plenty of those.
Yes.
Where people have used their imagination, or
Yeah.
whether there's been
I think that's
cross-boundary
key.
working across organisations. Okay,
Yeah.
it
I
doesn't
think
have to
that's
be in the
really
same
key.
specialty that you work in. It could be in oncology and you work
Yeah.
in gynae. But if there's a local precedent, that's one that you can use.
That's key.
So yeah,
Yeah.
get beyond the strategic stuff and think a little bit tactically about
Yeah. Yeah.
people's relationships and some of the basic things they need. One
Yeah.
of the things they might need, it could be as simple as someone saying, I can fund a meeting room one afternoon. We'll get everyone together for a couple of hours. We'll put on some sandwiches.
Yeah.
I'm not trying to trivialize the role of key account managers or companies, but this is where you come in. You could
Yes.
just be that final thing that brings people
Makes it
together
happen.
across sectors.
Totally. I think there's a few things there that I just want to go back and pick up with you because I think you've absolutely nailed something that I'm absolutely passionate about when I'm working with industry and advising them. Look for track record. And it doesn't need to be the service that you're working with. It can just be the fact that the hospital trust or the GP federation or the neighbourhood team or the network have got a track record of partnering, collaborating, working with industry, outcome-based
Yeah.
contracts. Look for track record. It's a great indicator. Previous behaviour is a good indicator of
Yeah.
what likely future behaviour is going to be.
Yeah. And just to reiterate the point, I think you agree, Scott. It could be in mental health and you work in a
Yeah,
totally different area.
yeah,
Yeah. You'll be surprised how much of that is transferable.
yeah.
And that's what helps you to take away the obvious obstacles about people worrying about risks and things like that, which is a
Ah,
classic
totally.
NHS thing.
Yeah.
So keep the faith.
Keep the
It is
faith.
possible. People want it to happen, and
Yeah.
there are local examples of it happening already.
Yeah, yeah. Brilliant. Absolutely great answer, David. Really spot on and very aligned with my thinking. If I move it on just a little step further, again, one of the other things that comes up a lot in my work is risk sharing agreements, sometimes called gain share. Long
Yeah.
discussed, relatively still rare in practice. I've had a couple in my work over time, but not for a while. What do you see as the kind of key ingredients for a risk share model? And what are the pitfalls that both NHS and industry have absolutely got to avoid?
Yeah, and I think the first one of it is picking up immediate theme. I wasn't expecting it to be so immediate, which is just about simple clarity and honesty and be
Yeah.
yeah. What I look for once you get beyond the pages of compliance documentation when I'm looking at a potential project, let's do it simply. Let's imagine I work in a primary care network, say.
Yeah.
What do I put in? What
Yep.
does the company put in? What's the risk to each of us? What I
Yes.
often hear on these occasions is all kinds of hypotheticals of risk. And when you actually play it through, it's not a nice phrase, risk war game. If you war
Yeah.
game it through, the risk is actually quite marginal, and you can build in the contingencies around that. Yeah. So people tend to be scared about all kinds of things that probably
Yes.
won't happen anyway. Yeah. Whether it's and to clearly separate them into compartments. What's a clinical risk?
Yes.
Is it a financial risk?
Yeah.
Is it a risk to reputations in some way? And to be really clear about specifying them and get
Mm.
very simple on the language. And then I think they can usually be resolved But invariably, it starts off with the thing I started off with. What do you want us to do?
They do.
So
Yeah.
do we have to supply a training day? Do we have to supply
Yep.
nurse time? If it goes over budget, what exactly? What exactly? So that's the question I'd ask all the time: is be precise, be
Yes.
exact, war game it through, and then you find out it's a lot simpler and less risky than people think.
Yeah.
Okay, that, that's my
I think you've
advice.
made again a really good point that often we look at it in totality. Well, I liked your word that you used earlier, segment it. What's the clinical risk? What's the financial risk? What's the path? Look at it in step by step and actually address each of the concerns as you go. And it's much easier to take people with you than if you, it's like, I suppose, like a bit like following a recipe. We know what we want at the end, but it doesn't start out like that. It's all the individual ingredients are
Yeah.
totally segmented until you mix them.
Yeah, and you've got to remember from an industry point of view, the people in the NHS side, just how many people they've got to bring together.
Totally.
Yeah? And
Yeah.
they sometimes underestimate on your side the number of moving parts on your
Yeah.
side for compliance and managerial
Yeah.
approval and the changes you're going through as a company.
Yeah.
So just be honest about those at the start. My
Yeah.
final bit of advice on all of that is to be careful. Is to it's much more successful to be modest in your
Yeah.
outcomes. Yeah. So there's a temptation. People sit in front of me and say, we can do this, we can do that, and it will get I don't know, some opportunity cost benefit to your organization. I'm
Yeah.
going, great, you sold it to me. Oh, and then it'll get people back to work, and it'll
Yeah.
alleviate the pressures of Brexit.
Yeah.
Or stop trees being cut down. And you're thinking, whoa, 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 hang on a minute.
Yeah.
Let's just go
I
back.
was
Let's
happy
just
where I
put
was.
things,
Yeah.
yeah. And let's focus on that and let's not spread the decision space too much. Is
Yeah.
to keep it very, anyway. So it seems to be a favorite word of mine at the moment. It's about precision. Let's just be
I think that's
precise.
a good word. I do
Okay.
think that's a good word because, I mean, one of the observations I make about certainly working with general practice just now, but the whole of the NHS, we're drowning in workload. We haven't got the people to meet the demand. So yes, we want innovation, but that innovation has to be without adding extra work, extra steps, or any extra complexity. If you do any of those things, you can almost see people going, that's not for me, because it's adding. It's what we want to know is what are we taking out, really, is where we
Yeah,
want to
that's
end up.
great. And my final point, you just reminded me of something I would say on all these things, is be very clear at the start with somebody, set yourself a time limit
Yeah,
and
yeah,
say, okay, it's 20th of January. If we, on both our sides, if we can't get this progressed by the 4th of March, we're
yeah,
going to walk away and we're going to agree to walk away.
yeah.
Yeah.
I
I
think that's
think
a really good
everybody out
point.
there will say, "Oh, I've been involved in stuff that's been a couple of years, and it goes this
Yeah.
and that and goes right." Yeah, set yourself a time and give some urgency and put some lids on it.
It's a great, again, another great point because the number of times I'll hear, oh, we've got X number of projects on the, and I'm like, yeah, but how many of them are really within that 2 month window? How many of them are 6 months, 9 months, 12 months or more? You can't really count them.
Yeah,
And yet we have that habit, we do count them. Yeah.
right. Good.
Um, Again, one of the other things so this is again learning from David. One of the things I did right back at the beginning, in fact, one of the first times I met you in Newcastle when you were on the commissioning side of the fence, and I took this away and I've really embedded it in my work all the way through, is what we commonly call PLICS, Patient Level Information Costing System. What Scott, in simple terms, says is costing every step in the pathway, not in
Yeah,
theory, but in practice. Patient level, so we can see where the resources are actually being used, where variation sits, and what really changes when outcomes improve. So, how do you believe PLICS could probably be more effectively used to underpin outcome based contracts, the risk sharing agreements that we're talking about, particularly if we're going to justify cost or impact of innovative medicines and devices? Where do you see that fitting?
well, firstly, you've done a service to everyone, Scott, because there'll be people out there saying, I've never heard of Plex, despite the fact, as we're saying, you and I
Been
have
around
been
for
around a
years.
long time. It's been around a long time.
Yeah,
Yeah. The basic point is, if I'm looking to write a business case, I don't use HES data, I use Plex data.
you're like me.
Okay. HES is available. I'm not knocking the people who got it and supply it. It's
Yeah,
sometimes the most easily accessible or the only accessible source for people in industry. but it's price data, it's not cost data.
Yes.
Yep. So the example that Scott's talking about, there's a maternity unit on my locality. If they were in payment by results, they would get what? About £1,000 to deliver a baby. The
Right.
real cost of a baby being born at that unit is £23,000
Look at it.
because it is the cost of running a unit in a small rural area
Yeah, of course.
divided by the number of women who have a baby there. Yeah. So cost and price are different things.
Yeah.
So when you're looking at business case, the real costs are important. You can also differentiate yourself. A top tip, if you're an account manager and you go into a hospital, you talk to people and you say, well, look, I haven't seen it, but what's your Plix position?
Yes. Yes.
Okay. Already you're different from the average bear, and it'd be really interesting what people say to you. It's not fantastic information.
Yeah.
Don't be put off by people saying, "Oh, it's not perfect." It's the best we got.
That's
And
it.
it's the NHS data, and that's what the chief execs and people like that
Yeah.
look at. Okay, so like Scott, I really advocate you use Plix data. It's fundamental. It's used across the community. It's used across mental health. It's even used in ambulance, and the ambulance Plix data is particularly useful for pharma. But there we are. There's a top tip for you.
That's a great tip.
I'm always interested in the ambulance data. It's going back to the P word. It's much more precise. So if you're looking at something like diabetic hypos,
Yep.
you've got to look at the ambulance Plix data, because if I have a hypo in the street, it's the ambulance service who's going to come and look at me, and that
Yeah.
might
Yeah.
not necessarily show up elsewhere. Okay, so could talk about Plix all day.
I'm like
If
you.
you're not familiar with it,
Yeah.
find out about it. If you are familiar with it, keep going, because you can get Plix data. I won't name the company, but I know there's a
Yeah.
company in surgical devices used a value proposition. They quoted Plix data, used it appropriately and referenced, and it made a big difference to their sales.
I bet
So
it did.
it's fundamental, as Scott says. If you're looking at the outcome based, if you're looking at setting your risk levels, if you're trying to work out the benefits, I mentioned something opportunity cost benefit before. So what's the cost of a district nurse going out and fixing a wound?
Yep.
Rural area or in inner city, they're going to differ, aren't they?
Going to differ
They're going to
massively.
differ whether it's somebody who's housebound with 6 other conditions, or whether it's somebody who's 32 and got a sports injury and they just need a quick dressing on their leg temporarily. Plix data reflects that.
It's brilliant. I'm with you. It is brilliant data. I'm finding it more and more. People are interested from an NHS side in what are all the steps in the pathway, because we hear a lot at the time. Well, I certainly pick it up in my work. I have to do this because it's the cheapest option, and I'm always, is it? Is it actually
Great
the
point.
cheapest option? Because a lot of the time, without being rude, we end up comparing bananas with cucumbers, because we're just
Yeah,
looking at the acquisition cost of one drug, one device over the other. We're not looking at, does it deliver the patient outcome that I'm trying to deliver? Extra steps, extra complexity, duplication, avoidable waste. We don't factor those in. The people are, a number of times I hear, oh, well, the people are there anyway. Yes, but what could they be doing if
that's
our pathway
opportunity
was
cost
much
benefit.
smoother? It's that opportunity. Yeah,
And
totally.
entirely, you and I are very passionate about
Yeah, we are.
medicines and devices. When you look at Plix data, they come out in the context of a woman having a baby and it costs 23,000, right? That's an extreme example. But what medicine or dressing or what sutures that lady has,
Yeah,
that's immaterial when it costs 23,000, right? But you even bring it down to things like, I mean, obvious example is generic statins, but
yes,
um, somebody, a company the other day, a director of a company said to me, I won't name what it was,
no,
it
no.
wasn't medicine, it was a device. And she said, the only problem with this is it's expensive. I said, don't use that word. But how much is it? Well, it was about 70 quid. You go back to when you mentioned when we first met, Scott, when I was a
Yeah,
commissioner,
yeah,
70 quid is free,
yeah.
right? You don't worry about anything that costs less. Healthcare is so phenomenally expensive.
Yeah,
So you can educate your customers if
yeah,
they knew that there is a drug or device and it costs a few quid more than something else. But as Scott's saying, what could achieve is a length of stay reduction,
yep,
or it could free up time of a doctor or nurse.
yeah.
It doesn't have to empty a bed. It doesn't have to make a
Nope.
redundancy. If it can produce that productivity benefit. So Plix, if you only remember one thing from Scott's great podcast, Plix is the friend of pharma and life sciences.
It really is.
Okay? It really is. It helps to prove your value proposition.
Totally. Without getting, again, I'm like, yeah, I don't want to name customers on that, but I had one recently where we're looking at a pathway and we were able to eliminate 12 weeks of the patient being seen once a week for 12 weeks with a change in the product, because what it meant was where we went from half of them not responding to treatment, we went to 1 in 10 not responded to treatment. So a huge workload release, but all that had been done was that's more expensive than that. Yeah, but you're not looking at the workload that goes with it. Once we'd established that, we had a completely different outcome, but it was
Yeah.
the Plix data that showed it.
Yeah, and it really shows up things like I was chatting with a practice nurse earlier who's master level nurse practitioner. So quite rightly, she'd be getting 60 odd thousand a year. And
Yeah,
she was talking about a change they've made in the practice. The healthcare assistants do it now. Okay, so
yeah,
they're getting paid less than half of it.
yeah,
That is the benefit that Plick starts to show up.
yeah, absolutely. I couldn't agree more, David. I could not agree more. If I, again, move the conversation on a little bit, where from an industry perspective, I get lots of, but like you do, we get lots of contact from the industry about where should I focus my efforts. You get a lot of people where they're totally focused on ICBs at system level. We've got others that work at provider level. I'm thinking more provider collaborative. I've got people that will just focus at neighbourhood level or PCN
Yeah.
level. Where should we focus if we're going to make our
Um,
outcome-based
I'm
partnerships
going to give a
stick?
slightly different answer.
Go on
I
then.
would say you should focus on the people who are most able to respond to what you're going to say, and so you've really got. I mentioned at the start about segmentation.
Yeah,
There's broadly. I'll be interested what you think, Scott.
yeah,
There's 10 to 20% of the NHS which is progressing at the moment, going ahead,
I'd agree.
using the opportunities of what we're going through,
Yeah,
and the rest is stuck. I'm
yeah.
not having a go at people because
No, it's not
there's
a
all kinds of
criticism.
reasons why they might be stuck. I'm in
Yeah,
an ICB that is not changing very much. That's not the case elsewhere. There's different financial pressures or
yeah,
CQC pressures and other
yeah,
things like that. But if you need to find the people, the right people. Now they could be at neighbourhood. I was actually just talking to somebody who's leaving an ICB to work at neighbourhood level as part of the voluntary redundancies.
okay.
Now they are just as innovative.
Yeah,
They are just as different. They're just as attractive to you in the industry, in the ICB, as they now will be in the neighbourhood.
yeah,
So look at the person
yeah,
and what they represent in terms of their cultural affiliation and their ability to move things. So it matters less, I think, about whether it's wound care or it's
yeah,
MRI scanners, whatever. It's find the right people and the right organisation. There are thriving ones and there are ones that are stuck.
yeah.
You need to find the ones that are going to be progressive. And the rest of it, I'm not sure too much. There's rarely been a time, even we as a relatively small neighbourhood,
Mm-hmm.
we could agree an outcome-based contract for many products.
Yeah,
Okay. And I would say if we have a chat in a year's time, that would include medicines as well, or many medicines that
yeah,
are
yeah.
used in primary care. So don't worry about your product necessarily. I am working, in fact, tomorrow I'm working on it, on us doing MRI scans.
Wow.
Now, who would have thought that at
Who would
primary
have
care
thought that?
level?
Yeah, exactly.
Okay.
Yeah,
So find the right account, if you like,
that's it.
and the right people and the right mentality and the people who are trying to work the project through. And don't worry about what layer of the system it is.
I'm so pleased you said that because I've got your outlook. There is no one right answer. There just
Yeah,
isn't. There isn't one magic bullet to this. It really is about, I think one of the phrases I use a lot with industry is be curious. Ask curious questions. Put the product to one side, just leave it
yeah,
over
that's
there,
great.
and ask really curious questions about what keeps David awake at night from a work perspective, what's turning over in his mind. What are the top three things? You can ask them about what his personal goals are from the neighbourhood. What's the neighbourhood trying to do and achieve? I remember I had a lovely customer. She's still a good customer, and Catherine won't mind me naming her. Catherine Patrick. She's medical director for primary care for Somerset Foundation Trust. And I remember speaking to Catherine, and she said to me, Scott, the issue I have is that I really don't mind the industry coming in and having 20 minutes, half an hour with me. I'm very open to it. And I remember putting her hand up and she said, but what I really want you to do is to ask me lots of good questions about what's on my agenda, then pick something off it that you can help me with. And
Yeah.
I'm going to engage. But if you give me a heavy product pitch, I'm just going to wait on you going through the door. And then that's the meeting over and I've forgotten we've even met. Yeah.
The top tip I learned from somebody years ago about in-call behavior is you should speak about 20 to 25% of the time, and the customer should fill the
Yeah,
rest. And
yeah,
you
agreed.
sell against what they say when they reveal their needs and build up the trust. And I think it's strange people have moved away from that.
Yeah,
If people do come and see me, the iPad comes out,
yeah.
and straight away they're into it, without understanding what you just said. What's on my
What's on
metaphorical
your agenda?
whiteboard?
It,
Yeah,
it's a real struggle,
yeah,
isn't it,
split
for
against.
industry to get beyond the product features and start conversations about the things we've talked about today: PLIX, shared risk, outcome based. That still seems to be a real struggle. Is there any advice that you would give the industry leaders who are genuinely trying to shift the internal culture and the external offer towards the value-based proposition? What would your advice be to them?
I do. It sounds simplistic, but to get close,
Yeah,
it's the thing. Exactly what you're saying there is they need to talk to the like the lady you just mentioned.
yeah,
That what they shouldn't get put off with, let's say the woman that I'm talking about, my colleague this morning, let's call her Sue. For now, she's moved from an ICB to a neighbourhood. I've got a feeling somebody's going to say to their bosses, Sue's gone from the ICB. Well, that's the end of that then. Instead of saying, well, she's just gone across to transition to a role in a neighbourhood,
yeah.
totally different role in some respects, but should be doing very similar
But
things.
she will.
And she's just as curious, she's just as innovative, and she's probably still got as positive a relationship with
Yeah,
companies. So I would like to see more people come out and about. I often give the opportunity for people to come out.
I know
Some
you do.
companies take it up, some don't. And we take them around the practices, we get them to meet
Yeah,
people. Yeah. The more you're in that kind of mode and doing the sort of things that you advocated,
yeah.
it's you don't have to do things in a hurry.
No,
Without being too trite about it, you've got to walk in other people's shoes. And
so
yet,
true.
I hear people, in fact, leaders in market access in industry, will say to NHS people, "Well, I know that what your priorities are. I know what West Streeting's telling you," and you think, "Hang on a minute."
Yeah,
Yeah, just ask them some open-ended questions and see where you go, because you might be in for a surprise.
yeah.
Um,
I had
and I
it this
think we would
morning.
both agree that the
Yeah,
NHS generally, I don't think has ever been more open to working with industry.
completely,
Would you
completely.
agree? Yeah.
I totally
And the
agree.
opportunities there.
I've got customers now, David, that if we roll back literally just pre-pandemic, if we use that as the benchmark, I've got customers that would have said to me then, Scott, we don't really work with industry. We don't, for a variety of reasons, but we don't really do it. Who are now saying to me, Scott, you couldn't find us a project that will look at A, B, and C. Or
Yeah.
we've got DNF is a real problem for us. If you know anybody, I'm now regularly getting requests. Can you find an industry partner for us from organisations that prior to pandemic would not have talked to
Yeah.
industry? They've never been more open to it.
Yeah. Absolutely. At every level, whether it's
Yeah,
scientific research through to can you get us a bit of software? We want to try it out and we want to give
yeah,
it a go.
absolutely spot on,
Can
David.
you support an away day? Uh,
Yeah,
our practice nurses meet up once a month. They accept classic kind of sponsorship and presentations from companies, and we sometimes struggle to get people to support it.
yeah,
And you
just
think, they're prescribers, they're
yeah,
interested. And it goes back to something else you're saying about the ability of people to push upwards. Yeah.
yeah,
So if those practice nurses are influenced and they have a go at me and say, so why haven't we got this? And everybody else has got this point of care device, or everyone else is using this drug.
yeah.
It has an effect.
Of
The
course it
clinicians
does.
are very, very effective.
I
So,
often highlight that to
yeah,
people. If you win the clinical argument, they can engage the business development manager, the business manager for the
yeah,
department, the business development manager for the federation or the network or the neighbourhood. They can get contracting and finance involved, and suddenly things
yeah,
begin to move.
yeah, absolutely. They can be your best salespeople.
Yeah, totally. I've got one last quick question for
Yeah,
you.
what's that then?
So, if I get you to crystal ball gaze and you look ahead for the next 4 or 5 years, so kind of the end of this parliament, where we might be, in terms of NHS and industry collaboration, just like we've been talking about, never been more open to it. Can you paint me a picture of what you think a mature, embedded, outcome based partnership might involve, and whether or not PLIX or data would play a role in it? What would that
Yeah.
look like? What does
Yeah,
good
and
look
it's
like?
easy to do because I'm very fortunate where I work and where I live. So let's use some new terms. In
Okay.
less than 5 years, in 2 years, we expect to have the first Advanced Foundation Trust and to be the first IHO, Integrated Healthcare
Yeah, I would
Organization.
be stunned
Yeah.
if you're not.
With a multi-neighbourhood provider contract. What that allows us to do, go right back to the start of Scott's question. So the reason why am I still here when I could have retired, right? Because the hope that we're going to have this. So I mentioned earlier as well about a clinical director for diabetes. The
Yes.
hope is that she will control a multidisciplinary
Of
team
course.
that is all the way from Zumba classes,
Yep.
fitting type 1 devices to pumps to kids who are 10 years old,
Yeah.
all the way through to not cutting people's feet off and everything in between, and her being the clinical leader of that with a group of people around her. So you can look at the budget on that.
Yep.
You can say we're going to use a preventative medicine and it stops someone having their feet cut off, therefore it will save 15,000 quid or something like that. And as I always say, the feet don't grow back. Yeah.
No, they
So
don't.
you get all those kind of benefits.
Yep.
We could be close to that. The challenge that you guys have got, whether it's a year, 2 years, or 5 years, is the variation.
Yes.
We're progressive on that. You can go to other areas of the country, Scott would name them, and they're in similar positions. But there are other areas where they say, we just can't imagine that.
Yeah.
We just can't get people together. We're so busy firefighting. We've got such financial problems. We've got a huge problem to do with our maternity unit with the CQC in, and until we just can't move forward. But that hope exists. Now, we've got 65,000 patients. We would expect, certainly in less than 5 years, the reason I was talking about MRI scans, we'll have neighbourhood health hubs. We would hope to have those operational next year, three neighbourhood health hubs. That opens up amazing opportunities for everybody on this call, whatever you make and sell, okay? But imagine one team, the public, bless them, think there's one team, health and social care.
Yeah.
I'm a trustee of the hospices.
Right.
We've just got System 1. So that's all to do with me as a potential patient, the specialist nurse in the hospital, district nurse, tissue viability nurse, practice nurse, the hospice staff, people potentially, I don't know, from Mind or Macmillan, everybody having an impact on my care as an individual. All the clinicians being able to see that care and having one single record, that opens up all the opportunities to everything that Scott's talked about. So the final thing I wanted to say, if you're looking for a proxy of where to go first, where's the places that are most advanced on single patient records?
Yep.
And having that shared aspect across teams. They exist already in many localities in the country. We're actually a bit further behind than some, and trying to furiously catch up. Okay. But
you're right.
in less than 5 years, we will either have achieved that, or we'll have some real problems, some real challenges. There's no alternative to that.
Yeah, that interoperability is so important. I had that conversation in a different part of your ICB this morning to do with mental health patients. Exactly that. We've got to have one version of the truth, one patient record, one single record. Is where they're going. I often often highlight to the companies, do not bring something else that needs another login. I've got to log into that, log out of this, and you pass. Just don't. It has to be interoperable with what we've got currently.
Yeah, well, that's the thing, I'm saying about going out and meeting people. It's not about the relationships. You and I, we'd scream out to people, come and have a look at a GP screen and see how proud it is and the way that the systems interact. And that'll teach you a lot about. So if you sell 7 different drugs in the same category, why is it such a challenge that maybe yours has a small market share? When you see the screen, and the fact that one of my rhetorical questions I often ask companies, how long's a GP appointment? How many people would a GP see in a day? And sadly, people are clueless about that. If you think in practice, a GP's got 6-7 minutes to really see you?
6-7 minutes, that's it.
So that screen and that crowded screen, and as Scott's saying, if a patient's got an app for asthma, one for heart disease and one for arthritis, it's not going to help.
Not going to happen. Yeah? No.
Exactly. Interoperability, all the rest of it. Yeah. That's great, Scott. Really enjoyed it.
David, thank you. I'm going to ask you, will you be happy to come back again? Can we keep a track?
Anytime. You made me think about all kinds of stuff now.
That's brilliant. Listen, an absolute joy, a real pleasure to get us both in the same room, comparing notes and having a chat. I'm so very, very grateful to you.
Oh, anytime. And good luck to everyone out there. Keep going. That's my main message, right?
That's the one. It's the right message as well. Keep going. Thank you, David.
Thank you. Bye-bye.
Take care now. If today's conversation has struck a chord, you'll love the Embedded Edge community. This is an online platform for people who want to stand out with better positioning and a deeper understanding of how decisions are really made inside the NHS. With practical frameworks, real-world analysis, and behind-the-scenes customer insights, you'll sharpen how you show up, engage, and embed your work. So please join Embedded Edge at www.scottmckenzieconsultancy.com. Thank you.